Welcome, everyone. We have assembled an exceptional panel for you today, each with a unique vantage point on what continues to be a pressing topic, challenging radiology groups. So, how to successfully negotiate with hospitals in an environment where the stakes are high and the operating realities are pretty daunting. So, we're going to work to cover a lot today, from strategy to structuring. So I will briefly introduce you to each of the panelists. They all deserve pages of recognition and a walk-up song, but in the interest of time, I'll be brief and dive right into our discussion. So Audra Frezza. Audra has spent 20 years in executive roles leading large groups across various specialties. She is currently the CEO of Boise Radiology Group, bringing a single practice operational perspective to our discussion today. Audra has also presented at RBMA on this topic along with Steve. Dr. Labib Haddad. Dr. Haddad is a highly respected diagnostic and interventional radiologist with more than 2 decades of leadership experience in radiology practice operations and hospital-based care. Dr. Haddad currently practices and is the chairman of West County Radiology Group in St. Louis, Missouri. Dr. Haddad brings physician leadership and a large health system experience to our panel today. Thanks for joining. Steve Mims. Steve is the founder and the CEO of PBS Radiology. He's a trusted authority in radiology financial strategy with decades of leadership across billing operations, contract negotiations, strategic planning, business valuations, physician practices, and payer environments. Steve has a practical and proven understanding of how radiology groups can approach negotiations, and he brings a broad national experience to the panel today. He's presented both at RBMA in different areas and also published materials on this topic. So thank you all for your willingness to bring your unique perspectives and experience surrounding this topic to our webinar today. We really appreciate it. I'm gonna jump right in from there. So Steve, you've worked with radiology groups across the country for over 2 decades. When you compare what contract and negotiations looked like maybe 5-10 years ago to what you're seeing today, can you identify what has fundamentally changed?
Yeah, there's been remarkable changes in the 30 years that I've been in radiology. And, in the 20, 30 years ago, 15 years ago, there's no doubt that the leverage has changed since then. Hospitals in the past, they had a lot of leverage, and radiology groups were really just more concerned about getting their contracts renewed. Now things have obviously changed. It's a perfect storm in the environment, that we're in now. It's really about money and the need of money for groups in order to support the services that the hospital is requiring. So what that's really turned out to be is groups having more leverage. There's no doubt about it because of the shortage of radiologists that are in the industry. As I mentioned, the perfect storm. It's reimbursements are down. The baby boomers are here. They're requiring more services. And radiologists, because there is such a drastic shortage of radiologists in the market, we're competing with groups all over the country in order to hire, in order to staff hospitals, and it's become increasingly difficult. So based on the supply and demand of that radiologists obviously can go out and demand more money. Do they want to be in the hospital or do they want to be at home? Because they can just read from home now in their pajamas. So that's what we're competing with. So the dynamics have definitely changed, not only for the groups and trying to staff their radiologists, but for the hospitals' lack of leverage in that as well. Now they're just more concerned about, how do we keep our radiologists here? How do we keep them happy? How do we keep them meeting the service needs of the hospital? So now as contracts come up for renewal, now you're talking about the groups needing the hospital support, the financial support in order to hire radiologists, because the competition is so great for the radiologists in the radiology market, and the hospitals need those radiologists to be in their contracted group, otherwise their services just aren't going to be met. So yeah, there's been there's been a change and nothing like I've seen in the 30 years that I've been in this industry.
Yeah, sounds substantial. Dr. Haddad, from where you sit as both a practicing radiologist and a group chairman, how has the relationship between radiology groups and hospital systems evolved? And what does that mean for how groups need to kind of approach these negotiations today versus before? You're on mute, I
I'm
believe.
muted. Well, now
There you
now
go.
you can hear me. Yeah, thanks for having me. And as Steve was saying, there's a lot of different new pressures on the hospitals and on the practicing radiologists. There are definitely downward financial pressures of reimbursement, both to the radiologists and to the practicing groups. When we wouldn't be having this webinar, this conversation, if things were bountiful and everybody was happy and satisfied. We're having those discussions because as a private radiology group, we found ourselves in a situation where it's extremely hard to hire and to retain talent and partners because as it's known now, it's decentralized. You can be sitting in Alaska and reading for Florida and vice versa. And so there's a relationship that, like when I joined this group 20 some years ago, you were part of a group based in the hospital. You were part of the hospital. There was some kind of organic relationship beyond just being a radiologist and a hospital. In addition to the fact that, as Steve had said, there were a lot of radiologists, and therefore these were like 10 years ago, it wasn't unusual to hear that the hospital just dismissed the whole group overnight and they brought in another group. Well, this is not even a possibility right now because of the shortage. And to bring up something from other meeting where what is the relationship with the hospital? Is it a relational relationship versus transactional? And many of the group who have stepped up or asked for support or stipend, they're going to see a change in that relationship. Suddenly now you're asking for support, and that doesn't come just one way. Now you are in a different relationship with the hospital from an economic and a business relationship. So for most private groups, it's very dichotomous because you still have a workforce that's still at the hospital and are still maintaining that hospital-based group. You have to. You have somebody has to do the tumor board. Someone has to do the interventional, the procedure. Someone has to do the consults. And yet those same groups have now a different arm, which is a telerad arm that, totally removed from the hospital, and they have really no relationship. And so within the same group, you're going to have those same what I was referring to, transactional and relational relationship with the hospital. And you need to be able to navigate those differences when you go up to the hospital system and you plead your case why you need financial support, which it sounds weird because, as we just said, radiologists are so rare to be found and we cannot hire them. And yet the negative financial pressures make it so that in order to keep those radiologists at this location working for this hospital, we need to offer them something better than the other locations or other hospitals.
Thank you. Yeah, talking about that positioning, relationships, building some leverage before you get to the table, and that conversation begins. Steve, I know you've said that, leverage is built years before any first contract proposal is presented. What does that actually look like in practice, and what are the specific things groups can be doing right now to position themselves for these later outcomes beyond the relationships that Dr. Haddad was just talking about?
Yeah, it's really creating an environment where your radiology group is not viewed as a commodity. You don't want hospitals feeling like they can just go to an RP, for instance, and completely replace your group, because it's not that way. And if they made the mistake of going to RP, they'll soon find out. And so how do you do that? How do you set your group up so it's not viewed as a commodity? It's providing exceptional service to the hospital, to the referring physicians. It's building relationships with the C-suite, with referring docs, with the ER docs. It's hiring top-notch radiologists. It's providing exceptional on-site services, call, after-hours coverage, attending meetings, being part of the services that the hospital offers, attending things like tumor board, cancer committee, quality, ER. It's really being a part of the hospital operations where the hospital is viewing the group as a significant part of achieving their success and their high service levels.
Mhm.
And outside of that, also having regular meetings with the C-suite. I like to recommend that, hey, have a Friday morning coffee with the C-suite, with the CEO, with the radiology department director, have a regular lunch, and even another level, try to develop a personal relationship. I know of many radiologists that go on hunting trips, they go on ski trips, different activities with the C-suite or CEO or COO. And ultimately, though, why are we doing that? We're doing that to build trust. And if you have the foundation of trust, it'll go so far in your negotiations with the hospital.
Thank you. Audra, what have you done operationally within your practice to make the group more indispensable to the hospital? And how has that translated into maybe stronger negotiating positioning for your group? I think you're on mute.
Thank you. A lot of the things that have already been mentioned, BRG is a group that's over 50 years old. We were fortunate in that we had already established that relationship prior to getting to the negotiating table, which I think is super critical. If you're working on that at the same time that you're going to be doing the ask, I think that's formulating a different conversation and plan and thought process to make sure there's just as much value that you feel like you can bring, regardless if you feel like you need to or not. There is a perspective from the hospital that they don't want to pay the money, that they didn't have the capital set aside. Perhaps if this is the first subsidy for your group, it was the first subsidy for our group. And so just some of those operational things, strong referring doctor relationship. The physicians in the hospital really like our RADs. The RAD techs really like our RADs. So over the years of work and just the continued culture and how they naturally work as humans was extremely positive for us because they were extremely well liked. Versus other departments we had heard had approached the table and been a little bit more difficult with the negotiations. They were known more as those folks who just said no instead of saying yes and supporting the hospital programs. I think those negotiations turned out very differently. So the long and short of it is they had already carved a path with the relationship and the conversation and the level of subspecialized work that they had provided and that we continue to try and raise the bar on. And so really their work spoke for itself. And then it became a business conversation to figure out how we best conveyed why it could not continue in the way in which it was occurring because of shifts in the market from that standpoint. So we stayed on course of providing extremely level of high service and saying, look, we want to provide this service. This is not a thing where we're going to try and tit and tat one against the other. We genuinely want to do this. This is why we can't. And this is why this is not viable long-term.
Yeah, thanks, Audra. You all made great points around relationship building, really understanding who you're working with and what their pain points are to kind of find, that team approach and when you go in. So with that context in mind, let's looking at how groups build leverage and what it actually takes to walk into a room and be ready kind of to get to that contract place. So when we're thinking about hospital leadership, Steve, walk us through what you mean, when you say the most effective proposals connect radiology needs to hospital priorities. And how does a group figure out what those priorities actually are specifically?
Yeah, well, first of all, if you're doing the if you're doing appropriate preparation and communication and having those regular meetings that I discussed earlier with hospital leadership, being part of their executive committee, for instance, talking to the ER, going to their committees, quality, all of that, you'll understand what those needs are. And so what's your strategy in going in? You don't want to just go in and ask for more money. That may be the end result. Hopefully it is that you get money. But from a hospital standpoint, really trying to put yourself in their shoes, how would that be received if they came to you and said, hey, we want more money? So yes, that's a result, but focus on why you need the money. What will that achieve? Make sure that the hospital understands that you're very aware of what they're trying to accomplish. So if they provide more money, what will that achieve? It'll achieve lower turnaround times, which they're trying to get and achieve as well. So the service levels are going to go up. Is the ER throughput? It's lowering inpatient days. It's improving the quality. So it's really that collaborative approach of getting to what you want, which is more money to bring in more radiologists to provide those services to the hospital, but focus in the communication with hospital leadership on those areas and what it will achieve for the hospital versus just going in and saying, hey, we need more money.
Yeah. Where's the shared investments? Dr. Haddad, as a physician who sits in leadership meetings and, as part of a large health system, are there questions or concerns that you see from C-suite that you feel like you failed to anticipate, or the hospitals failed to anticipate, and how could groups be more prepared for those types of conversations?
Yeah, I mean, the biggest problem that I see the biggest mistake doing is assuming. Either they assume that the hospital system knows exactly what your group is going through. And the problem is that we've been with this hospital system for about 60 years, just like others groups talking, and we've been providing, as far as I'm concerned, excellent service. And I've been told many times, we love working with you guys because we don't have to herd your cats. I mean, you're taking care of your group, you're providing a service. And it's very easy when this is happening for those hospital administrator to forget that you actually have the same struggle dealing with your group that they have dealing with their own, and because you're presenting a very polished package. So when you suddenly come and you say, I want more money, you're going to go, what's happening? We didn't even know. So being in those meetings and as Steve was saying, being close to a lot of those administrators. And for me, like I've grown up in those, like I've known some of those people for 20, 25 years. So we know each other very intimately. And so then they understand what you're going through, and you also understand what they're going through. The hospital is not the enemy. The hospital is actually, for us, it's a number one partner, and you want to keep it at this level. And now, when you say things that I'm not prepared to, every now and then you hear that there's a new opportunity coming, and somehow the hospital may offer it to their integrated physician as opposed to us. And you have to go back and you have to refocus. It's like, well, you don't want to bring up the thing, oh, this is a contractual agreement or what have you, but I think we can do this better, and I think we can do it in a more expedient way, and mostly maybe even cheaper than what you're trying to do. So that would be like one area which worries me, because like I said earlier, they're working on building a new hospital now, and we want to position ourselves to be the partners, and we want to make sure that we actually get asked first. So these are the little things that sometimes you don't expect or anticipate until it comes out. The other thing you don't anticipate is that the hospital is going through financial pressures just like you are. Mm-hmm. And I think if you come to the table and you acknowledge that, and you acknowledge, hey, we're in the same boat and we have the same mission. We want to serve our patients in the best way, and we don't want to waste resources. People appreciate that. Just going back, like what Audra said, if you have been a partner with your management, with your hospital long enough, and they know you, when you come and you ask for something, they do realize you need it. You're not just coming as a, last minute cowboy. And you hear a lot of horror stories, people just walking into the C-suite and demanding and making threats. And we can talk about this later on. This never ends well. It never ends well. But yeah, so that's it for me here.
Yeah, thank you. More of a conversation, it sounds like, of partnership and shared investment than give us more money. On that note, just transitioning into looking at pitfalls, mistakes that you all believe that groups make and, that you've seen from your experience. Steve, I'll start with you. What do you feel like the most common mistakes radiology groups make in weeks and months before a negotiation actually begins? And are there things that maybe they do that undermine their position before they even get to the table? Besides, some of the things you've already discussed in relationships that, that you've seen really undermine or hinder outcomes?
Yeah, without a doubt, lack of preparation and lack of collaboration and cohesiveness within their own group, within radiology groups. They all need to be speaking as one voice. Some other mistakes that I've seen, waiting until there's a crisis. The time to negotiate for a stipend is last year. So if you haven't done it, or years ago, so if you have not had these conversations, if you have not been preparing, yesterday's not soon enough to get started. And if you wait until there's a crisis, then you're going to end up in a situation like Dr. Haddad said, where you're going into the C-suite and all you're doing is just asking for money. It's panic. We have radiologists leaving. We're not going to be able to staff. We're burning out our current radiologists. We can't cover call. All of those things. So you cannot wait until there's a crisis. And that also results in negotiating from emotion instead of, utilizing your data. You go in there and you're apprehensive, and as soon as they say no, and you're not spending the time to educate them of what the situation is in radiology, it's natural for emotions to start bubbling up a little bit, and that will not end well. So you got to keep emotion out of it. Having it in there is definitely a mistake. As Dr. Haddad also said, you have to recognize the hospital priorities as well. When they know you understand the situation that they're in, they're trying to achieve high service levels, they're under financial pressures, they're under staffing pressures. If you don't acknowledge those, that's a mistake, because it has to be a collaborative relationship or collaborative negotiation. And if all you're worried about is me, and our group, that probably is not going to end well. And even if you were able to get more money, that you're probably going to come up with a structure that's not going to be sustainable, which I know you're going to talk about that later with some questions, but so we can address that. So as I mentioned, not being aligned as a group, make sure your group is aligned. You're speaking through one voice. You don't have every member of the group or many members of the group out talking different stories. Have single or maybe a couple of people within the group, radiology group leadership, leading those discussions. If you don't have that, then you're going to have loose lips, and we all know the saying, loose lips sink ships. And if you have people that are within your group that are out communicating outside of the single voice, they're probably not going to be communicating what's necessarily been agreed to or discussed in a meeting. They're probably going to have some emotional discussions out there. So make sure they're not out there just talking to all members of medical staff. Keep it within a confined group when you have the negotiations, and not only within your group, but a confined group of the hospital leadership and medical staff that you're speaking to. It's not comfortable if the C-suite knows that you're out there having all of these conversations and they start hearing things, because we all know the communication channels. That what you have said out there probably won't be exactly accurate from what is being communicated back to the C-suite.
Reinterpreted, yeah. Great points. Thanks, Steve. Dr.
Sure.
Haddad, Audra, you've been through these negotiations. Is there a mistake you've seen that you think you wish that every group could hear before entering into this process, or advice you could give on that?
I would say never assume, and this just kind of wraps back around to what Steve just said. You know, it seems when you're sitting in a radiology practice and you're trying to recruit and you're seeing your recruiting numbers, what you're paying folks and benefits go up, and you're seeing the financial ramifications of some of these hires, and sweat equity becomes now they're a cost, honestly, to the group just to get them in the group at times. And you feel like you're lucky to have done that with the market. It's really easy to get into a place where you go to the table and you're extremely frustrated and you're like, everybody has to understand this picture, surely, right? That this is not sustainable. And especially from the hospital standpoint, they do have their struggles, but IR, for instance, we have 7 IR doctors that provide a really high level of service, that take a lot of call, and 10 APPs that support them, and they're expensive from that standpoint, and they make a lot of money for the hospital. And so we were well aware of that. It's one thing to be aware and to position that in your conversation. It's another one to approach the table from an ego-based frame of mind or assumption that surely the hospital will understand that as well. I don't know that I've seen it firsthand, but I've heard stories where of other groups, and I'm sure most people on this particular webinar have, you know, they really thought they were going to go to the table and pound their chest and this was going to be a done deal, and the hospital said, go pound sand. There are hospital administrators who will make bad decisions because they don't want to be painted into a corner. So if you do anything right, don't paint them into a corner. Nobody likes it. It doesn't feel good, and it's just not a win-win at the end of the day.
Thanks, Audra. Yeah, so we've talked about positioning and strategy. I think another key we all know is that data drives successful negotiations. So as we look at numbers, can we get specific about, you know, what data matters, how to present it in order to build a compelling case? That said, Steve, what role should a formal fair market value analysis play in the negotiations?
You know, I think it really plays a role of having an unemotional, outside, uninterested party in the conversation. And it really justifies what the group is asking for. If you just go in and ask for money, but you don't have any data to back that up, it's pretty hard to justify what you're asking for. And I recommend, and Audra's group did this, it's a great success story, that they both got a fair market value. So the group got a fair market value, and I've seen this among many groups, and then the hospital gets a fair market value. I've seen it in groups where the group would get one and the hospital wouldn't. I've seen it in groups where the hospital would get one, the groups didn't. I've seen it where neither the hospital or the groups get one. And 100% of the time, it works much better in the negotiations if both the group and the hospital is obtaining a fair market value. As I mentioned, it plays that unemotional role of an uninterested party, an outside perspective on the services that the radiology group is providing, and what are those services worth. And that's really ultimately what the group's trying to achieve, is we just want to be paid what fair market value is. And that's what going out and making that small investment, I think, achieves. And a lot of groups I've heard say, oh no, it's too expensive, we'll just let the hospital do it. I think that's a mistake. I think the group needs data when they go into their negotiations, and that fair market value analysis will provide that. And I think in most instances, not all, but in most instances, the hospital will respect the fact that the group has made an investment to go out and determine what the fair market value of those services are. In Audra's situation, it was just, ideal. It's where you actually had the fair market value firm that they hired and the fair market value firm that the hospital hired actually working together and having some communication at some point. In my opinion, it just doesn't get any better than that.
Do you feel like there were any surprises in any of these and what it revealed, or specifically to Boise and Audra's group? Audra, you can answer too, like in the positioning, were there any surprises that the analysis revealed?
I don't think there was surprises for us. This was our first go at, how do we frame, what do we ask, what does the market look like, and what is the FMV going to come back at? And by going to an outside party, it also provided us an opportunity to have what we felt like someone in our corner from an expert standpoint who had done a lot of FMVs and could say, I would look at a number and I would say, wow, I really don't like that salary number for a physician, for example. And she's like, oh, but this is how they get it. And this is the percentiles they use. And I go, okay, how do we get to a higher percentile? And so you get to start to ask some of those questions, especially if you haven't done it. And even honestly, if you haven't, we really peeled it apart to try and understand it, because not just for this time, but for next time. Because as things also then move and shift, as we have exclusive, basically exclusivity for radiology reads within the largest hospital healthcare system in Idaho. But things move and you want to know where that play is for future negotiations as well. And so it just made us much more versed on FMV, and we felt like we could ask questions of someone who was actually going to be extremely transparent and honest, because we were paying them to do that. So it was a win for us for sure.
Yeah, thank you. Dr. Haddad, from a physician standpoint, how do you make sure the data you're presenting reflects the full scope of what radiologists are doing, including work that doesn't show up cleanly and work RVU numbers, light call burdens, additional leadership that you're putting in, or consultations?
I mean, yeah, you have to have your house in order before you go and ask, because the last thing you want is for them to point out to you your shortcomings. They will ask you, what did I write here? You wanna be open to the hospital views and suggestion without opening the kimono. They are going to ask you a lot of questions, and they want a lot of supporting data. And if you cannot come up with this, or worse yet, if you do not know, that's worse. So for us, we started with the basic FMV in-house. We came up with a number, and then we hired a company to do their own FMV to see if we're matching, to make sure we're not delusional. And we were very close. And then we went to the hospital, and we felt very prepared. And funny enough, they base the FMV on different than we do. We base everything on work RVUs, right? They base it on FTEs, and that's not the same thing. And the problem with that also, because as you start losing FTE, if they're going to pay you less, now you have really more work and you're getting paid. So this was a surprise at first, but that's what I'm saying. Know what is needed before you go in. And if you can tell how the hospital is going to work on their FMV and who they are using, then you can have a better idea. The other thing is, as you said, I mean, position yourself and, hey, we are running the Department of Radiology at 5 different hospitals in Missouri, 5 other hospitals in Oklahoma. So we're not just dealing with that one hospital system. They need to also know that you are actually ingrained with their whole healthcare system. We offer a high level of tumor board involvement. We offer management. As you were saying earlier, we are very, very close with the hospital employee. We're involved with, with the tech week, with the nurses week, with, every year we actually bonus the hospital employees that are not our employees, because we feel like we're family and you have to actually be part of the group. So we brought up all of these things that are in many ways non-tangible, all the hours that we're putting in management, in education, in being part of the group, in addition to the FMB. Now, the truth is, at the end of the day, it's those numbers that are going to speak louder for the money part, right? And then we deal with the hospital system that's very clearly says we do not pay for call. If you do not pay for call, then you have to make up that money elsewhere, because as Andra said, we have 13 interventional radiologists. We provide interventional radiology at 4 hospitals. that's a lot of income for the hospital, but it's a lot of pressure on the group. I mean, I'm not bringing something new by saying the IR, the R and IR dichotomy. The group feels that IR is an anchor. Me as an IR, I don't think so, but and by the same token, the hospital loves having the IR. So you need to also paint this, in a positive way. The other thing, ask the hospital, what do you need? Oh, we want to become a comprehensive stroke center. All right, how about you help us help you? We can work together on this. And then once you know what they need, other than the fair market value, I think you will have a better idea of where to go. Again, as I said earlier, the first sentence here on my little paper, Audra, is do not assume. And that's absolutely what you just said. Do not assume they know your plight, but also do not assume that you understand. Go and ask them, what do you need? Because they may need more than or something different. I think one fundamental thing with those conversations is you need to have a clear understanding of what you need and what you want. These are two different things. And most likely you're going to end up somewhere in the middle. And if you don't know the clear difference between these two things, you're setting yourself up for disappointment. Steve, what you said earlier made perfect sense. You need to have a unified voice. Especially outside the boardroom. You go in the boardroom and maybe there will be talk and what have you. Do not broadcast this. This is not to be, you don't want the hospital to broadcast what your personal business, and you do not want to, this is a recipe for disaster. Do not go back and say, well, this is what you did with the pathologist, or this is what you did with the anesthesiologist. There are NDAs. Nobody's supposed to be talking about these things. So don't get yourself into legal trouble either. But Karen, I don't know if I answered your question. I think I strayed a little bit, but I'll let you go on to your next one.
And then some. We appreciate it. Thank you. So once you've built the case and you're actually ready to structure the deal, let's talk about some smart, I guess, agreement structures and what potentially could be also left on the table. Steve, can you kind of briefly walk us through some structures that you've seen, fixed subsidies, work RVU based models, hybrid arrangements, what's working, what's becoming more common?
Sure. Yeah, I'd be happy to. And I'll focus on briefly. I know you've got a lot to get through. So
yeah.
One model is what I call a coverage model. It's a hospital that's needing services or hospitals, and you're just basically looking at what it's going to cost the group in order to do that and cover that. And perhaps that's through an income guarantee, for instance. Another type would be where you have, and I don't agree with some of these models. I don't think they're sustainable, but they're models that I've seen. A separate contract just for after hours. A lot of groups will go out there and, gosh, the after hours is just so expensive. We need help with that. And that's all they'll go to the hospital for. As again, I don't agree with it, but that's a model I've seen. Most everything, most popular is the work RVU model. Some of those are just a straight work RVU model. Other ones that I've seen are separating out different things. So separating out IR versus DR. Separating out, besides the work RVU, components like covering the Nighthawk and after hours and IR call and billing. I've seen some groups have models where they looked at, rather than after hours, they were looking at IR, and that IR is a burden on the group, and they're not. It's a loss leader, and they don't want it to be a loss leader. So the hospitals is either paying or hiring IR themselves, taking that component completely out of the group. Again, I don't agree with that, but that's a model that I've seen. As I mentioned in the talk at RBMA, we've done some rural hospitals. They have the ability in their cost reports to get reimbursed for some things. So we used a work RVU model in order to come up with a dollar amount, but then we incorporated that in the hospital's cost reporting so they could get reimbursed for portions of that, and that was categorizing it in the monies in particular areas rather than just keeping it as a work RVU. And then I've seen hybrids of all of those things. It's crazy the number of models that I've seen out there, including quality payments. I know there's some people out there saying quality payments aren't as popular. I continue to see it personally. So yeah, those are some of the ones that I've been a part of.
Thank you. Looking at defining fair and overlooked components, Dr. Haddad, what components of physician work do you feel like are most commonly undervalued or overlooked in stipend negotiations? And what should groups be fighting to get compensated for that many maybe currently are giving away for free?
Well, as a starter, you should not give anything for free. But that's the biggest problem I've seen and talking to many groups is that we used to be a 12, 15-hour coverage, most radiology groups, and then you had night hawks and you had VRAD and what have you taking over. And in some models, the groups paid for that, and then they did the final read in the morning and harvested. In some other models, the hospital paid for that, did final reads, and then more and more, a lot of those services are just also drowning and are not fast enough and not as dependable, especially when you're talking about stroke and about trauma, level 1 trauma center. So a lot of private groups like ours have been moving slowly to a 24-hour coverage, and that's what we're offering. And that's why I said you need to let the hospital on a regular basis know what you're doing, not just when you come and ask for money. The costliest thing for a group our size is the overnight coverage. The next one would be the evening coverage, and also the IR and the neuro-IR stroke. I mean, these are 4 things that fundamentally, you, as a group, if you don't pay attention, you're going to lose money on those. And yet the hospital now comes to expect that service. This is no longer, because we are a 24-hour coverage, this is no longer a special thing. And if you haven't really talked to them and made them aware of how expensive that is compared to day coverage, they're not going to be willing to pay for that. And as Steve had said, some groups have extricated and said, hey, we just need money for the evening and the night coverage. Some group have blended all 24-hour work to try to come up with a number that covers everything. And some groups came up to the hospital and says, here, this is our DoorDash menu, pick what you want, and we can only cover 80%. And I think a lot of those solutions work short time, but unfortunately, some of this is a little bit short-sighted. You have to decide as a private group in 2026 how much of your independence you want to give up. How much do you want to, if you're going to be paid directly, let's say, and have the hospital do your billing, that's the first step into becoming integrated, right? So I fundamentally think you need to take care of your own billing. You're going to do a better job than they do. And but that's, you want to be paid per RVU, that we would all love to. But if your hospital system doesn't want to pay you per RVU, they want to pay you per FTE or whatever, I think the minimum ask is a scalable stipend, because it's a very, very, very painful experience. I've at a closed meeting with SR, I described it, but I will not bring this now here how I described it, but it's a very painful process, not just for the group, but also for the hospital, for everyone involved. Nobody wants to come back every year and renegotiate a stipend. If you're going to negotiate a stipend, I think the minimum should be a scalable solution that grows with you as you grow. We are all growing. The numbers are growing. I mean, obviously, PBS is in the billing business. You can tell that everyone's number are just going up and through the roof. Our group in the last 2 years, we hired another like 25 to 30% more radiologists. So do not aim for the short and then find yourself 2 years later drowning. You need to have a scalable solution no matter what you do. You need, in my opinion, you have a blended solution. So it takes, in effect, your stroke, your nights, your evenings, and your IR coverage as well. I feel very strongly against giving up part of your group to the hospital. Like, say, you can have IRs. Not only you're dealing with the IRs as a commodity, but also your group then, with the advent of AI and what have you, you're going to be in a much, much weaker position 5 years from now if you give up your presence and your procedurist. Again, you need to tell me when to stop talking.
I'm going to skip through some of this just to keep us going, but even the best prepared groups with the strongest data is going to hit some resistance. So let's talk a little bit about, navigating some of these hard conversations. Steve or Audra, what do you do when the hospital leadership, really pushes back hard, questioning whether a stipend is justified, proposing a number that's well below market, or just going silent altogether?
Go ahead, Audra. I'm happy to chime in.
Yeah, go ahead and start it. I'll chime in after you.
Yeah, I think the conversation just has to focus around that collaborative relationship that we've discussed. It's not just about the radiologist just asking for more money. If it focuses on that, it's going to fail. It's really approaching that conversation with how do we make sure that the hospital is achieving the quality and the success levels and the metrics that they're trying to achieve. They go sideways because the hospital they're not educated, as we talked about earlier. They don't understand, as both Dr. Haddad and Audra had mentioned, don't assume they understand the position of the radiology market. Many of them do not. So make sure that if it does start to go sideways, that you just back up, don't get emotional, focus on education, focus on understanding, focus on collaboration. And as far as the amount of money and hey, we don't think you deserve that much, that's really where the fair market value comes in. And that if you have the basis and the foundation that we talked about the trust and the relationships and all those things that both Audra and Dr. Haddad mentioned are wonderful ways to build trust and show that you're a part of the hospital's success. I've heard of Dr. Haddad's group, as well as other groups, even bonusing the radiology department staff and doing things for them on Rad Tech Day, even though they're not their employees. It really just incorporates that you're there to ultimately achieve the success of the hospital, and the success of that hospital being providing just exceptional service and quality to their patients.
Audra, you have any?
Yeah, I was just going to tag on that to say, for us, just situationally, they had just brought me on and decided to shift strategically from a practice administrator role to a CEO role, which signaled something to the hospital, number one. Two, there was a change of presidency, and both are really strong leaders, but the one that's currently was coming into the president's seat, warm, approachable, very likable, but distinctly driven and forward thinking. And so I think that combo approach of coming to the table, as we've all said, prepared for an educational conversation and not assuming that they understand what the rad market is doing and how hard it has shifted, and starting to have some of those conversations. We didn't even have access to the C-suite before I came on board and the president changed. And for some reason, we don't even really know why that switched. And so we started to get the attention of the C-suite with these conversations. And so that year-long negotiation was able to take place. But I think part of it was really just saying, look, we understand your reimbursement's gone down, but let me show you a graph of what's happened to our practice and the practices nationally, because it's visual and it actually had an impact for them. And walking through, again, we're not just coming here from greed because a lot of people are doing it. We're doing this. This is a business proposition. And so I think that just trying to keep that focus, and the cost of rads, the difficulty of hiring, and the burnout of physicians, we want to continue to do what we're doing. But if you want the Treasure Valley to continue to provide this or receive this level of service, something has to shift.
Thank you.
Yeah,
Great insight.
I'm going to add
turbo-
one quick thing. One quick thing. I'm sorry. RBMA was a great tool for us. When we started that, actually, we came back from RBMA, and Andrew Martin, the president of the group, and myself, and well, actually, he did most of the work on that, put down a slideshow for the C-suite using the RBMA data and saying, this is national. This is not just us. We are looking at maybe 1 to 2 years before, as Steve said, do not come to them when you're falling off the cliff. But listen, this is going to happen. The other thing that I showed them, and they don't like it during the meeting, I ask every radiologist to show the list of job offers we get every 15 minutes. I mean, the truth of the matter, which is very sad, is if we lose this job, we can all be employed in 20 minutes. That's how bad it is. And I think that drives the message home. It's a national problem. It's nothing, but we want to be here. We want to be with you. Kara, you take it from here. Sorry.
Thank you. No, those were great points. Thank you. I know we're going to run out of time before we can get, we had so much great content here, and hopefully we can do a follow-up, because I think it's probably worth the value in getting back with all of you. But I think just if you can give a 1 minute, you guys have talked a lot about relationships and dynamics, and they're so critical, but so is holding up your end operationally. So if we talk about performance accountability and contract terms, Dr. Haddad, from your understanding with hospitals wanting to tie their stipends to performance and metrics, as a physician leader, how do you approach that? What metrics do you think are reasonable? Where do you draw the line in 1 minute?
In 1 minute. So really, truly, the only metric we have with our hospital is turnaround time, and we're blowing this out of the water. I mean, that's the truth. And whenever turnaround time starts going down on outpatient and non-stats, that's when you come back and you say, well, that's why we need your help. I mean, we're reading at maximum speed, but you want to put some metrics that you're going to meet every day. You don't want that contract to be, I've heard some groups that say, nope, we're not doing any metrics. Quality metrics in radiology don't exist to some level because the volume is so huge that you're not going to have a quality problem most of the time. It's a turnaround time. And if you focus on that, I think most radiology groups that are near to properly staffed should have no problem with the stats and what have you. The other thing, I think it's not all about money, so other than like our hospital system was able to get us out of hospitals where we no longer had to do IV coverage. We actually were able to reduce the in-house hours and in-house presence. We're struggling with PEDS coverage. They understand that. So some of the stuff is not just about money. It's about working together. But yeah, do not tie yourself to some metrics that are going to come back and bite you, because they will come back. And if you find somebody in the C-suite who doesn't like you, that's what they're going to latch on. So try not to. Turnaround time is fair. Look at the national averages before you sign up for something that's draconian to your own group. I think I'm at 42 seconds. No, I'm joking.
Good job. Yeah, good job. Just to wrap it up and kind of let's maybe shift our focus forward, because the groups are doing their best work today. What should they be thinking about with what's coming next? So this is to all of you, whoever wants to answer. Where do you see these models evolving over the next 3 to 5 years? Are we moving towards more standardized structures? Will negotiations become more complex? And is there any one thing that you're doing right now operationally or strategically to position your group for the future that you'd like to just mention to our group here?
Not to be that guy, but we haven't talked about AI, and that's where it comes. I think in the next 5 years, you're going to see a lot of that. There's many parts of what we do that are ripe for AI take over. The question, who's paying for the AI and who's going to be managing it, who's going to be responsible for it, and who's going to collect the money from it. I see that in 5 years, it's going to be a little bit of a hybrid situation where some of the stuff, the hospital is like, yeah, don't worry about that cardiac CTA. We have it. Don't worry about that screening exam. We have it taken care of because we have AI. We paid for it. So I think as an independent group, you need to have, and I don't know, it's very hard. This field changes every 3 months, every RBMA or RSNA or SIR we go to, it seems like things are just moving so fast. And I think it's important to, but that's one of the many things. I'd let Audra and Steve obviously add to that conversation.
Yeah, the only thing I would say is optimistically, I hope it's a new day for radiology. When I came into radiology from a background of neurosurgery and orthopedics, we all know that gastro's been supplemented, honestly, nationally on some level, I think with a lot of healthcare systems for a long time. Anesthesiologist is the same way, or anesthesiology. So I don't think you rest on that. I don't think we can. I think it depends on the consolidation level of we continue to have different iterations of hospital size, different states. I think that will continue to present a different negotiation consideration nationally, but the more that it gets simplified to a large takeover footprint, I think there's definitely a shift that will potentially occur, which won't be good for any of us, quite honestly, from a healthcare quality standpoint or otherwise. But I really don't like, and I'm a little bit stubborn. I do not like, I'm even just being with the practice shy of 3 years. I think radiology's gotten the short end of the stick for a long time. And I don't think that we should position ourselves to be okay with that anymore. And for this just to go away and say, hey, we gave you a gift for a few years, but the gift is going away. I don't see a shift in the market or hiring or demand. And so I don't see a shift from that standpoint.
Thank
I
you. Final
completely-
thoughts, Steve?
Yeah, I completely agree with what both Dr. Haddad and Audra were saying. And we've heard many people say that these stipend models aren't sustainable. And I think a lot of stipend models aren't sustainable, but that doesn't mean they're going away. The key is going to be develop stipend models that are sustainable. The radiologist shortage isn't going away in the near future, and probably for many years. So there is going to continue to be a need for radiology groups to go to their hospitals for financial support. And hospitals are going to need to provide that in order to provide the service levels and quality levels that they want for their to meet their own metrics. So I think the models will become more standardized. I don't think they'll all be the same, but they'll be more standardized. They'll be tied to volume. They need to be reviewed annually to make sure that the stipend amount is working. They need to be data driven, no doubt. And I think there does need to be mutual performance obligations. It's understandable if the hospital is writing the check every month or whatever, every quarter, whatever it happens to be. It's understandable that they are going to want some performance obligations tied to that. So models in the future will not just be paying for after-hour coverage or IR coverage. I think they're going to need to be developed and move forward so they are sustainable. As far as groups go in the trend, I'll try to talk really fast here. I had a radiologist friend of mine that he always told this story, and I love this saying. This football coach used to say, if you stand around, you're going to get hit. I think that applies to radiology today and radiology groups. If you're not out there and you're not looking ahead and trying to stay one step ahead, like flying an airplane and having on autopilot and staying ahead of your airplane, you're making a mistake. You need to stay ahead, look at the trends, look at the what ifs. For instance, what if I lose a physician? What if I lose 2 physicians in the group? What if I lose IR? How am I going to cover that? Strategic thinking outside of the box. What if a hospital merges? What if they build another hospital, like Dr. Haddad was saying? What are we going to do as a group? Because that responsibility is going to come on us. So it's really thinking about ways of positioning your group to always be in a position of strength. I also like to say position your group to be the gobbler versus a gobblee. I think we'll continue to see consolidations in the industry, no doubt. So do you want to be that group that the other group is gobbling up, or do you want to be the group that is from a position of strength and being the gobbler? And lastly, it's about service. Focus on the relationship, spend the time, prepare, be outcome driven. And I think my minute's more than up. Sorry.
Thank you. Great insight, everybody. Excellent discussion. Thank you all so much.